First of all, I thank Dr. Kodishwaran sir and Rajesh Babu for giving me this opportunity in front of this. Moving on to the topic, that is anatomy of carpal tunnel. Just I want to dust your anatomy knowledge. That is carpal tunnel. It is an osteofibrous tunnel between the carpal bone and the overlying flexor retinaculum. That is the fibrous band which arcs over this carpal bones. Just a briefing about the carpal bones. That is, it is derived from the Greek word carpus, meaning wrist. That is, it has got a proximal and distal row of carpal bones. From lateral to medial, they are scaphoid, lunate, triquetral, pisiform, and then distal row, trapezium, trapezoid, capitate, and hamate from lateral to medial side. So the various carpal bones from medial to lateral in the proximal row are pisiform, triquetral, lunate, scaphoid, and hamate, capitate, trapezoid, and trapezium from medial to lateral in the distal row. This is right hand, right articulated skeleton. Okay. So the pisiform alone is a unique bone which articulates only with the triquetral, whereas rest of the carpal bones articulate with each other. So this proximal row of carpal bones, namely scaphoid, lunate, and triquetral, will articulate with the articular disc over the wrist joint. So this carpal bone has got a dorsal surface and a palmar surface, and the dorsal surface of the carpal bone is more convex when compared to the palmar surface, which is deeply concave. So it has got some ulnar projection and radial projection. Ulnar projection is formed by the pisiform and hamulus of the hamate bone, and radial side it is formed by the tubercles of the scaphoid and trapezium. Because of this projection, the carpal tunnel is made much more concave over the palmar surface. Coming to the carpal tunnel, how is it formed? By means of the overlying fibrous, that is flexor retinaculum. So underneath this arch of the flexor retinaculum, you very well know that all the flexor tendons of the digit, and over which the median nerve, the hero of this carpal tunnel, passes over this flexor tendon. So the main function is to strengthen the corpus and to augment the flexion mobility over the wrist. So a word about the flexor retinaculum. It's a broad fibrous band, about 2.5 centimeter, both in length and breadth, and attached medially to the pisiform and hook of hamate, and laterally it splits superficial and deep lamina, where it is attached to the that is scaphoid and trapezium. So this laterally it provides a groove for the passage of the tendon of flexor carpi radialis. So this is the cut section of the this wrist over the carpal tunnel. So structure passing superficial, that is ulnar nerve artery, palmar cutaneous branch of the ulnar nerve, tendon of palmaris longus, palmar cutaneous branch of the median nerve, superficial palmar branch of the radial artery. These are the structures which pass superficially. This we made a cut section of the wrist, anatomical cut section of the wrist in our cadaver lab. So here you are able to see this is the lateral side that is occupied by the scaphoid, proximal row of carpal bones, scaphoid, lunate, triquetral, and pisiform. This is a transverse section of the right wrist joint, and this is at the proximal end. So here you are able to see this all the flexor tendons, mainly flexor digitorum superficialis and flexor digitorum profundus, laterally flexor pollicis longus and flexor carpi radialis. And just this is the attachment of the flexor retinaculum. Beneath the flexor retinaculum, we are able to see the median nerve. So this is why it is, since it is a lunate in articulate surface, it is named as lunate bone next to the scaphoid. So this beneath this flexor retinaculum, this tendon will have a synovial sheath which is having a visceral layer and a visceral layer, this innermost layer which is closely applied to the tendon, and a parietal layer. So this synovial sheath over this flexor tendon, that is namely FDS and FDP, forms ulnar bursa, and over the flexor pollicis forms the radial bursa. This radial bursa will communicate with the thumb whereas the ulnar bursa will communicate with the little finger. So yeah, these are the structures passing deep to the flexor retinaculum. That is, it passes through the carpal tunnel. So this is a section of the wrist at the distal end of the carpal tunnel. So how we are able to identify is, this is the hook of the hamate bone, and this is the flexor retinaculum, which has got a superficial slip over the ulnar vessels and nerve, that is called as Vijayan Canal. So this underneath this is the ulnar artery and ulnar nerve on the medial side, and here you are able to see the median nerve just beneath the flexor retinaculum and all the cut section of the flexor digitorum superficialis. Deeper to is the flexor digitorum profundus and flexor pollicis longus. This is at the distal end of the carpal tunnel, distal part of the carpal tunnel. So this is the attachment of the flexor retinaculum. So this is the labeled picture of the distal section of the carpal tunnel. This is the hook of the hamlet, where the distal part of the distal end of the flexor retinaculum is attached. You are able to see the ulnar vessel, flexor retinaculum, and this is the lateral side, that is trapezium, trapezoid, capitated hamate. So this median nerve lies somewhat in the midpoint of the carpal tunnel. So the dislocation of the lunate bone can cause compression over this flexor tendon as well as over the overlying median nerve. So common cause of entrapment mononeuropathy, and it may be narrowed by so many causes, mainly that is rheumatoid arthritis and soft tissue thickening with edema and obesity, including pregnancy, and so many of the cases being idiopathic. And so during this symptoms will be accentuated during flexion of the wrist. Pain, paresthesia, wasting, and weakness are the main symptoms of the carpal tunnel syndrome. So this treatment, which will be dealt by the subsequent speaker. What I want to show is the dissection of the flexor retinaculum to show the carpal tunnel. This is the medial end of the superficial slip over the ulnar vessels. There is Vijayan canal, and so this palmaris longus, which occupies the midline in the forearm. This tendon passes over this flexor retinaculum. This is then flattens to form the continuous with the palmar aponeurosis. So this is the palmar aponeurosis, the apex of which is attached to the flexor retinaculum. So after reflecting this palmaris longus, you are able to see the attachment of the flexor retinaculum. So it is a band, fibrous band over the carpal bones, 2.5 by 2.5 in centimeter in measurements. This is the cut end of the flexor retinaculum to view the underlying structures. So immediately beneath the flexor retinaculum, you are able to see the median nerve. Surprisingly, so far, we also had the idea that carpal tunnel is nothing but the pressure inside this flexor tendon is increased, causing pressure over the median nerve. That's all. But interestingly, while dissecting this cadaver for this program, we have found out that along with the median nerve, we are able to see one other vessel, that is persistent median artery. That is persistent median artery, which accompanies this median nerve. This has been quoted in literature. Median nerve may be accompanied by median artery, persistent median artery. And one more thing we have seen in this cadaver is usually the median nerve, that is 5 centimeter above this flexor retinaculum, the palmar cutaneous branch will be given off by the median nerve. Here there is high division of this median nerve into a lateral and median branch. So this may also can cause pressure symptoms. Not only the entire median nerve gets compressed in carpal tunnel, because of the high division, any branch arising beneath this level or over this level, which pass through this carpal tunnel, can cause pressure symptoms, maybe resulting in carpal tunnel syndrome. And here just we have traced the recurrent branch of the median nerve, which supplies the thenar muscles, which usually arises near the distal border of the flexor retinaculum. So these are the tendons which is going beneath this carpal tunnel, namely flexor digitorum superficialis and flexor digitorum profundus. So to sum up, carpal tunnel is not only due to the entire compression of the median nerve, that is the branch, even starting from the artery, the ulnar artery, instead of passing over the flexor retinaculum, can pass inside the underneath the flexor retinaculum, and the median nerve may be accompanied by the persistent median artery. That also we have to bear in mind. And coming to the nerve, that is high division of median nerve is one of the variation. And sometimes this palmar cutaneous branch, instead of arising 5 cm above, may arise inside the carpal tunnel, and the recurrent branch, which usually arises from the distal border, can arise inside the carpal tunnel. Median nerve, instead of occupying the midline, can shift to the lateral or to the medial portion. Sometimes the tendon, the palmaris longus, instead of passing over the flexor retinaculum, can pass inside the tunnel. Sometimes the fleshy belly of the flexor digitorum superficialis can pass inside the flexor, that is inside the carpal tunnel. The first lumbrical itself may get arise from this to the index finger, may arise inside the carpal tunnel from the flexor digitorum superficialis. It may be considered either as the accessory slip of the flexor digitorum superficialis. All this can lead to compression of the median nerve, leading to carpal tunnel syndrome. So, surgeon should aware of all this anatomical variation of this median nerve and the associated vascular anomalies. That's all I want to tell. Thank you. Thank you for giving the opportunity. Sir? Thank you, sir.
Thank you, madam. Thank you.
Thank you, madam. We will have the final discussion at the end of the session.
Okay.
And in between, we will be having questions from the first speaker. At the end of the second speaker, the first question will be coming. And now we will have the second speaker. I invite Dr. Vijayan K for giving his lecture on clinical and electrophysiological evaluation for carpal tunnel syndrome.
Good evening, sirs.
1 minute, sir. Dr. Vijayan, sir. He has done his graduation from Tirunelveli Medical College and the MD from Madurai Medical College and DNB Internal Medicine, DM Neurology from Madurai Medical College, and ASN, American Society of Neuro Imaging. He is currently the consultant neurologist and neurosonologist at the Royalcare Superspeciality Hospital, Coimbatore. Previous position, consultant neurologist at KMCH, Coimbatore, and professor of KMCH Institute of Health Sciences, Coimbatore. And he was working consultant neurologist in Arul Raj Hospital, Tuticorin. Now I invite Dr. K. Vijayan sir to give his lecture.
Good evening, everybody. I would profusely thank Dr. Rajesh Babu and Dr. Thiruppathy for having given me this opportunity to interact with all the members of TNMSC. Now, a few words about carpal tunnel syndrome. Now, I think we went through a vivid description of the anatomy. The most important thing I would like to highlight in what Madam told us, a bifid median nerve, a high bifurcation, and also the persistent median artery. One of the commonest, one cause for common carpal. Can you see my slides, please?
Yeah, we can see. We can see.
You put a. All right. Okay, fine.
What Madam highlighted in that anatomy was very beautiful bifid median nerve with a persistent median artery, which we sometimes come across in 3% of the individuals as we do a ultrasound when we inject local steroid. A bifid median nerve with a persistent median artery, highlighted by Madam in her anatomy of carpal tunnel syndrome. Now, I would like to go through only a few clinical points and also the salient electrophysiological features of a carpal tunnel syndrome. One of the most common nerve upper limb compression neuropathies, as we all know, a symptomatic compression neuropathy of the median nerve at the wrist, that we all know that it's predominantly a demyelinating pathology, a demyelination of the median nerve due to compression within the flexor retinaculum. And it's characterized by pain, paresthesias, and very rarely weakness. And in extreme stages, you can also notice wasting of the thenar muscles of the hand. Commonly caused by compression, as we all know, and Madam had mentioned a few cases. The commonest is diabetes mellitus, obesity, weavers usually get this, milkers usually get this, milkers, patients with rheumatoid arthritis, fractures, and whatnot. Many other conditions, including pregnancy, can also cause a carpal tunnel syndrome. As Madam had already put this, the objective sensory defect, very important point I would highlight in clinical examination of a carpal tunnel syndrome is objective sensory deficits usually occur late in the course of the day, and they involve the median innervated fingers. That is, they spare the thenar eminence. Why do they spare the thenar eminence? Again, Madam had clearly highlighted that the palmar cutaneous branch of the medial nerve usually takes its origin before the median nerve enters the flexor retinaculum. Before it enters the carpal tunnel, the palmar cutaneous nerve branches off. Very rarely, as an anatomical variant, the palmar cutaneous nerve may go inside the flexor retinaculum. That time, it's a rare phenomenon. Most of the time, you should remember that sensation over the thenar eminence will be spared in carpal tunnel syndrome. That's very important thing. If the sensation over the thenar eminence is involved, if there is numbness, paresthesias over the thenar eminence, then it is not a carpal tunnel syndrome. We are dealing with something higher above the division of the palmar cutaneous branch, usually a pronator teres syndrome. That is what we will be dealing with, which I will come to later. So this is a critical sensory finding, is sparing of the sensation over the thenar eminence. If that is spared, then that definitely carpal tunnel syndrome. You can see how the palmar cutaneous nerve branch in blue innervates the thenar eminence and the proximal parts, and the distal 3.5 fingers and the dorsal aspect along the distal parts is innervated by the median nerve. The sensory loss or sensory impairment of paresthesias involve only these three nerves, these three fingers, and not the palm. Abnormalities on motor examination, I told you, very rare. Only after significant sensory loss. Weakness of abductor pollicis brevis is the most sensitive motor sign of CTS, and thenar atrophy is a rare finding, but may be present in severe chronic cases, and we've seen it in many patients, thenar atrophy. The diagnosis by doing this very classical challenge test, we'll come to that. Nerve conduction studies, electroneuromyographic examination, ultrasound and magnetic resonance imaging. I will not go into ultrasound and magnetic resonance imaging. Balance sign, as we know, hyperflexion or hyperextension of the wrist for the 60 seconds may produce the pain and paresthesias in the nerve distribution. Usually they complain of pain over this middle finger, paresthesias, and it immediately relieves. It gets released, but you must at least keep the patient flexed at least 60 seconds. That is a classical phalanx sign. A reverse phalanx sign is the opposite maneuver of the phalanx sign. It's for extension of the wrist. You can see the phalanx maneuver clearly portrayed there. This is how we should do the phalanx maneuver. And sign, as we all know, tapping on the volar wrist over the median nerve and produce paresthesias. It's highly specific. Sensitivity and specificity is around 50 and 77% specific. The flick sign, it's another important sign which is used to usually differentiate between a carpal and a radiculopathy, pain due to radiculopathy. Now, if the patient complains of pain which is relieved on shaking the hands, then it is always due to carpal tunnel. If the patient complains of pain which is aggravated by hand motion, it is almost always due to a radiculopathy. The very common confusion in clinical practice is whether it is a radiculopathy or a carpal tunnel. Remember, a carpal tunnel pain can extend up to the elbow, extend up to the shoulder. It is not only manifest, it can extend into the forearm, the arm, and even up to the shoulder. So, clear-cut, easy differentiate is ask the patient to shake his hands. If he just shakes his hands like this, if the pain gets relieved, then it is carpal tunnel syndrome. If the pain doesn't get relieved, rather it is exacerbated, it is a radiculopathy. Another clinical point to differentiate, ask the patient to keep the hand over his head. If the patient rests the hand over his head like this, and if the pain is relieved, it is the radiculopathies. Almost always radiculopathy. If the patient comes with this sign itself, this is a clinical sign of a radiculopathy and not a carpal tunnel syndrome. So that is what is mentioned in the flex sign. The direct compression test or the Durkheim compression test, again, 30 seconds you press over the carpal tunnel exactly at the distal point, and you can reproduce all the paresthesias which the patient complains of. Now you can do a double compression test. You can do the direct compression test along with a phalanx. You do a phalanx and also compress directly on the carpal tunnel. And this also reproduces the symptoms in mild cases. In mild cases, this is another easy way. The nerve conduction study is, of course, very useful for confirming that there is focal damage of the medial nerve inside the carpal tunnel, to quantify the damage using a severity scale and to define electrophysiology, whether it is a conduction block, a demyelination, axonal decay. You can see this is a grading. Electrophysiological Medicine, American Academy. Negative CTS is normal findings on all tests, including comparative and segment. Comparative means comparing the ulnar, ipsilateral, comparing the ulnar medial and ulnar contralateral, and
Speaker, sir, kindly unmute yourself and speak, sir.
Vijayan sir, unmute பண்ணுங்க sir, unmute பண்ணுங்க.
Okay. Minimal CTS is abnormal findings only on comparative or segmental test. It is comparative. When we compare the median and the ulnar, now I'll show you examples for that. Mild CTS is sensory conduction velocity slowed in the finger wrist tract, which is with normal distal motor latency. Moderate CTS is sensory conduction velocity slowed in the finger wrist tract with increased distal motor latency. So when the distal motor latency of the median nerve is increased itself, it is a moderate degree of CTS. And severe CTS is absence of sensory response in the finger tract with increased distal motor latency, and extremely severe is absence of even a thinner motor response, which is very rare. Yeah. Now I'll just go. You can see this is the distal motor latency. If the distal motor latency is more than 4 milliseconds, then it's usually a diagnostic of carpal tunnel syndrome. It's not necessarily should be 4 milliseconds. I'll go on later. I use these two parameters. Very commonly, I use 3 parameters to diagnose. Of course, there are a lot of criteria, diagnostic criteria, but I'll tell you 3 simple parameters which I use commonly in my practice. One is to see the distal motor latency. Compare this distal motor latency with the ulnar nerve distal motor latency. Now, if the distal motor latency is more than 4 milliseconds, then it's definite evidence of carpal tunnel syndrome. In this case, you can see it is more than 4. It is 5.1 milliseconds. I'll show you another one, which is a common thing which I use in my clinical practice. The F-wave latency comparison between the median nerve and the ulnar nerve. Now, usually, the median F-wave latency is shorter than the ulnar F-wave latency. That is, usually if the median nerve latency is 22 milliseconds, you say ulnar nerve latency, motor latency, F-wave latency will be around 24-25 milliseconds. But if there is a inverse of this, that is reversal of F-wave latencies between median and ulnar, that is the earliest sign of a carpal tunnel syndrome. Even if distal motor latency is not prolonged, even if sensory conduction velocity is not prolonged, if you see this on electrophysiological condition, this is the earliest sign of a minimal or mild carpal tunnel syndrome. Reversal of ulnar median F-wave latencies. That is, in simple words, at distal, the F-wave latency of the median nerve will be more than the F-wave latency of the ulnar nerve. Simple. This is one simple. If you see this on an electrophysiological study, this is definitely a carpal tunnel syndrome. So the grading is again another grading, prolonged distal sensory latency, peak latency will decrease. I told you all this already. I would like to highlight two more important points here. One is the anterior interosseous nerve syndrome. Anterior interosseous nerve is a pure motor branch which arises proximally in the elbow before the median nerve passes in between the two heads of the pronator arteries. The anterior interosseous nerve supplies three muscles. One, it supplies the pronator quadratus, it supplies the flexor pollicis longus, and it supplies the plexus to the index finger and the middle finger, flexor digitorum profundus to the index finger and the middle finger, and flexor pollicis longus, and it supplies the pronator quadratus. Now, in this condition, you may have a vague pain over the elbow. Usually, patients who have this repeated pronation supination, you may do a nerve conduction study, and the nerve conduction study, which we routinely do for carpal tunnel, will be absolutely normal. And these patients will be having an anterior interosseous nerve syndrome. The simple sign, clinical sign, is sensations will be absolutely normal because it's a pure motor nerve. And as I told you, it supplies these four muscles or three muscles only, three muscles. So if you ask the patient to make a fist, then he will show like this. This is a sign of benediction, or just like saints or God's bless you. It's a sign of benediction because the flexor pollicis longus is weak. The flexor digitorum profundus supplying the index finger and the middle finger is weak. So they don't flex together along with the other nerves. It's exactly the reverse of ulnar claw hand. Exactly the reverse of the ulnar claw hand. It's called a sign of benediction. If you see the sign of benediction, it's an anterior interosseous nerve syndrome and not a carpal tunnel syndrome, where here it is a pure motor syndrome and vague pain may be seen over the mid elbow or the mid forearm or the proximal forearm. Now, another differentiation point is between the pronator teres syndrome, again, which occurs in 2 to 3% of the individuals. One who has repeated pronation supination movements of the hands. Now, it is seen, not that it is not seen. In pronator teres syndrome, it will have all the features of median carpal tunnel syndrome, except that sensation will be impaired over the sensation is impaired over the pronator teres syndrome, and sensation is not impaired over the thenar remnant. So these are the three important clinical things which will come. The fourth thing which I want to mention is the presence of a double crush syndrome. You may have a C5 radiculopathy, C6 radiculopathy associated with the median nerve syndrome. So this is called as a double crush phenomenon. And this also can be not uncommonly seen in our clinical practice. So you will have both features of both a radiculopathy and a median neuropathy. And the fifth clinical point I would like to highlight is shakes his hand, pain goes up, carpal tunnel. If shakes his hand, pain persists or increases, it is radiculopathy. If the patient keeps the hand on the head like this, then it's usually a radiculopathy which relieves the pain. It's usually a radiculopathy and not a carpal tunnel syndrome. I would like to of course, there are a lot of medical managements and also surgical. Mild to moderate cases, we can do medical management. What medical management? You can do extension, flexion exercises. You can ask the patient to put the thumb inside the palm, close the fingers, and do wrist rotation. 5 times, 3 times a day. That will help. Of course, wearing of splints, especially in the night, in the functional position of the hand. Splints are ready-made splints are available. Of course, should not wear the splint tightly, snugly. It should snugly fit into the wrist. That also relieves. And of course, local injection of corticosteroid. This is a direct technique, directly injecting without guidance, directly injecting into the carpal tunnel. One, you have to identify, as Madam pointed out in the anatomy, this tendon, palmaris longus tendon. In between the palmaris longus tendon and the next lateral tendon, you will have the space. In that space, you have to inject the nerve. Be very careful. There you have to inject the steroid because you may sometimes directly enter into the median nerve. It will be very painful and patient may not forgive you. The another technique is to, this is a video to visualize the median nerve. This is the median nerve. You can see the honeycombing of the median nerve, honeycomb structure of the median nerve. You can see the honeycombing very clearly. You can see as I pass the needle towards the median nerve, and you can inject all around the median nerve. The others are the flexor, but always be careful to withdraw. You can inject all around. here I am injecting to the side and below. You can also go back, which I have not recorded in this video, go back and inject above and all around the median now. While injecting above, again, care must be taken to keep the beveled edge facing downwards, because if you keep it facing upward, most of the steroid will extravasate into the palm and may cause whitish discoloration, for which again the patient may not forgive you. So injecting technique is done this way. There are two techniques. One is direct injection, another is guided injection. Guided injection, you come from the side and inject. With that, I think I would close my topic here. Surgical treatment, others will be covered by the surgeons, next speakers. Thank you for the opportunity, and thank you for patient hearing. Sir?
Thank you, Dr. Vijayan sir, for the nice lecture about the electrophysiological evaluation. Before going to the next speaker, we will be having the first question for this evening. Naveen, you can put the first question. Vijayan sir, you stop sharing your screen, sir. Naveen, you can put the first question. Commonest carpal bone which get dislocated is. Commonest carpal bone which get dislocated is the first question. You can answer in the chat box itself. Okay, now we will go for the evening imaging CTS by Dr. Bavaharan Rajalingam from Thiruchirappalli. Naveen. Dr. Bavaharan Rajalingam is MBBS DNB FRCR. He has done his graduation from Tanjore Medical College and DNB from Meenakshi Mission Hospital and Research Center, Madurai. FRCR Fellow of Cardiac CT. Presently, the Managing Director, Consultant Interventional Radiologist, Magnum Imaging and Diagnostic Trichy, Consultant Trichy Fetal Medicine Center, Consultant Department of Interventional Radiology and Stroke International Unit, Sundaram Hospital, Trichy, Visiting Consultant GVN Hospital and ABC Hospital, Trichy, National Academic Lead in Obstetric Doppler Training and Samrakshan, and Teaching Faculty, Indian College of Radiology and Imaging. Now I invite Dr. Bavaharan Rajalingam sir to give his lecture.
Thank you, sir. Thanks for the introduction. Hope I'm audible.
Yes, sir. Audible.
Yes, sir. Hope my screen is visible.
Yes.
Yes. So after two detailed talks, let us go into the radiological evaluation of carpal tunnel syndrome. At this outset, I would like to thank the organizers and Thiruppathy sir for getting me here for this wonderful meet of neurologists and neurosurgeons again. So, yeah. This is the anatomy that we were all talking about, and in radiology we are more concerned at this level. There are two levels which we have to do the evaluation. Number one is at the level of the pronator teres muscle, where it forms the tendon. So that is one area where we have to evaluate. The other important area is in the flexor tunnel itself, the carpal tunnel itself. So as we all know, the carpal tunnel is formed by bony arch and the transverse carpal ligament, or that's the transverse carpal ligament, which forms the roof of the carpal tunnel, and you have the bony arch on the dorsal side. And you have multiple flexor tendons here, which is going to innervate into the fingers and thumb. And the median nerve is actually located here, which is in the medial aspect. So this is the diagrammatic correlation and the MR correlation. You could see here, this is the transverse carpal ligament, and this is the transverse carpal ligament here. And this are the multiple, the flexor tendons which is there, which are appearing hypointense on T2 sequence. So in MR, we have multiple sequences. We are interested in having a T2 sequence, STIR sequence, and a T1 sequence. In a very rare instances, we use contrast in carpal tunnel syndrome, which we'll see when and where. Now, this is the flexor, that's the tendon here, and that's the median nerve. So this honeycombing pattern, which was described by Dr. Vijayan sir in the previous talk, it appears to be slightly hyperintense. You could see here, that's a hyperintense nerve. This is always in the convex shape. You could see here, this is always a convex shape. So whenever there is a palmar bowing of this particular ligament, there is always a compression of the median nerve here. Now this median nerve per se getting compressed can be due to the pathology of the median nerve, maybe due to demyelination, or due to thickening of the nerve, or it could be entrapment, or it could be some other structures which is causing obstruction to or compression to the median nerve. So this is the anatomy that we are more concerned about. And another important structure which we have to evaluate in all the imaging is the palmar-cutaneous nerve branch. Because see, this is the palmar-cutaneous nerve branch, and that palmar-cutaneous nerve actually divides and goes even before the median nerve gets into the carpal tunnel. So we have to be very aware about where the palmar tunnel, whether it is MRI or whether it is ultrasound. We are concerned also not only diagnosing median nerve compression or any fluid or synovitis, whatever it is, but it is important to evaluate where the palmar-cutaneous branch is and tell the consultant, yes, the palmar-cutaneous branch is in the normal position or not. So this is the important role of radiologist, not only diagnosing, but also telling where the anatomy are. So this I'm going to skip because already has been in detail covered by Dr. Vijayan sir. And you could see here, this is the region of carpal tunnel. Now, if you draw an imaginary line in the distal palmar, that's the palmar crease here, and another line along the first web space, this is where the carpal tunnel is located. So we are also concerned about the median nerve, which is in this particular segment and also in this particular segment, because radiology here is about comparison of the median nerve, the thickness and the area. It's always the comparison of thickness and area in two different areas. In two different areas, one at the level of pronator treris and the other at the level of carpal tunnel. So we are going to compare these two areas. So whenever there is a compression, the nerve is going to be narrow, and proximal to it, it's going to be dilated. Because of the compression, it's going to be slightly enlarged in size. All right. So this was discussed again. So here you could see the abductor pollicis, which helps in the adduction, is actually given innervated by the ulnar nerve, whereas the flexion abduction opposition by the flexor pollicis brevis, the abductor pollicis brevis, and the opponens pollicis is supplied by the median nerve. Again, as discussed by the previous speaker, it is important to know that there is no sensory loss in this particular thenar eminent. So there can be atrophy, but the sensory loss will not be there because it is supplied by the palmar-cutaneous nerve branch segments. So this again, in the reverse order, even if the patient can't keep the hands in the supine position or with the palm up, we can actually take it in the prone position, where actually it is flexed and turned around. You could see here, this is the median nerve, and these are the flexor tendons, and this is the ligament. So this ligament runs from the scaphoid to the pisiform. So now that you could see here, that's the ligament, which is always hypoechoic in whether it is T1, T2, or any images, right? So most of the common causes, there is no clear cause because there may be degeneration, but the key risk factors are many, like the repetitive strain, you've got the rheumatoid arthritis, obesity, and perimenopausal period, the acromegaly, hypothyroidism. See, these acromegaly, hypothyroidism, usually sometimes in a few cases of severe rheumatoid arthritis, the carpal tunnel syndrome is many of the times bilateral. So as radiologists, sometimes we may have to compare with the normal hand, but if it's going to be due to some systemic cause, then probably it will be very difficult unless and otherwise we follow a proper protocol for this. So as discussed, so not only there are causes which can decrease, these are the causes that can decrease the size of the carpal tunnel, but if there are mass lesions, for example, there are ganglion cysts, it could be a nerve sheath tumor of the median nerve, could be synovial hypertrophy due to rheumatoid arthritis or amyloid, and most common, and one of the common in about 2 to 3% of the patient is about the bifid median nerve. So bifid median nerve can, see there are two, the median nerve, rather than being single, it is divided into two, and that two nerves occupy a larger cross-sectional area, thereby actually it's a normal spaced carpal tunnel, but since the nerve area is larger, it can get compressed and lead to carpal tunnel syndrome. Now, all these things has to be discussed. So as already discussed here, it is worse at night, wake up and shaking the hand is the most common. The pain gets relieved after shaking the hand. So it can be pins and needles, tingling, burning sensation, pain, and numbness. So these are the motor changes. So motor changes are like weakness of the thumb movements, grip strength may be weakened, finer movements may be difficult, and there may be muscle atrophy. So these are the most common causes of things. Coming on to the ultrasound evaluation. You could see here, I've just put the lines here for making you differentiating easily. Here you could see this in ultrasound, this orange line, which this is the transverse carpal ligament. Usually the ulnar artery is actually the medial. You could see it's medial and it is anterior to the ligament. It's always medial, anterior to the ligament. Sometimes this ulnar artery may be persistent and get into the carpal tunnel. So that is called as the median artery. That can cause compression on the median nerve. So median nerve always appears honeycombing. It's called as honeycombed nerve because of multiple fluid-filled structures there, which actually helps in the conduction of the nerve findings. So this is the scaphoid and this is the pisiform, and you will see the flexor tendon images. So the ulnar artery seen is anterior. So ultrasound is always an evidence-based study. It's very important to detect the median nerve enlargement. The CSA here, which I'm going to mention, which we are going to see in ultrasound and also in MRI. This is called cross-sectional area. Now, we'll always demonstrate a cross-sectional area which is more than 10 millimeters square at the proximal tunnel. Or there is one more criteria, which I'll come back. If there is thenar atrophy and the cross-sectional area is more than 15 millimeter, it is a severe carpal tunnel syndrome. We also diagnose conditions like tenosynovitis, masses and anatomical variants like bifid nerve or the persistent median artery. But it is also important as a radiologist for me to say, where is the Pharma cutaneous branch? Because it should not be inadvertently damaged, whether it is in normal position or does it have any variation. So this is how a median nerve is there in the wrist. These are the flexor tendons. You could see here, this is how we actually mark and get the cross-sectional area of the median nerve. You could see here area of 1.9 millimeters square. So again, a much more zoomed out image. This is how actually the median nerve looks like when you actually have a zoomed out image and very close evaluation. This is done at a very high frequency probe, and you could see multiple small hypoechoic areas. We call it as hypoechoic areas here, but this is how the median nerve looks like. So there is, importantly, there are three triads or three findings where I told you about the palmar bowing of the flexor. Usually the flexor retinaculum is always convex. If it becomes concave, then it is definitely a sign. Distal flattening of the nerve. As I told you, whenever there is compression, proximal to the compression, the nerve is enlarged. Distal to the compression, the nerve is smaller in size. We always take the area of the compressed and as well as the non-compressed area, and we see the difference. You could see here, this is how we evaluate the distance. See, this is the transverse carpal ligament. We draw a line from the scaphoid to the pisiform, and we see how much the distance it actually takes at the maximum convexity. If it is less than 2 millimeters, generally we call it as a palmar bowing of the flexor retinaculum. So enlargement of nerve is very, very specific, and because of a normal cross-section area of 9 to 11, which I told you around 10. But when I always told you that there should be a comparison of the same nerve at the pronator arteries level, which is the proximal, and at the carpal level where it is compressed. If the difference in cross-section area is more than 2 millimeters square, it is always very, very significant. There is also called as a flattening ratio, we call, where we take the short axis of the median nerve and divide it by the long axis of the median nerve. That is also one of the things. So a carpal tunnel, generally when we evaluate as a dynamic study. You could see here the same nerve, same level, but shows very different shape. This is because of the flexion and extension. So because of the flexion and extension, the flexor muscles actually, they change in shape and elongate. So that leads to slight compression and deviation of the median nerve, which is a normal phenomenon. This is how a short axis evaluation is done, area, and this is how a median nerve looks in the long axis. We just take a complete long axis. So we measure the long axis and the short axis, and we take the flattening ratio. This is a case of carpal tunnel syndrome where you could see that definitely the area is more, it's about 15 millimeters square, but you could see distally the nerve is smaller compared to the proximal, which is larger, which is, I don't even need to measure here, but you could see evidently the compression is here and the nerve is narrow here. This is a narrowed nerve, and this is the widened nerve. Again, you could see a narrow nerve and a widened nerve. This is how actually you evaluate this particular ratio. Sometimes, as I told you, but median nerve may be 2. Now, if there is this kind of a case, it is important to make sure that this is not a median artery. It's very, very important to put a Doppler and say whether it is a median artery or not. In MRI and in bifid median nerve, there is an increase in cross-section area of more than 4 millimeters square between the proximal third of the pronator quadratus level and the carpal tunnel is again very, very sensitive. So again, there was a discussion in the, by Dr. Vijayan sir in the previous talk, where actually he told about where he actually told about the nerve conduction study. So in the nerve conduction study, he told about the distal motor latency, which is about 4 milliseconds. So here it is 4 millimeters square. So it's easy to remember. So the 4 is both in the nerve conduction study as well as in the MR and CT. So this is a median nerve where you could see a bifid median nerve, but you could see a artery, median artery, which is thrombosed. Now, this is very, very rare. And this we picked up, and there was a thrombus which was there in the median artery. This is how a normal median artery looks when it is associated with the carpal tunnel. So the ulnar artery will be there, and the median artery is sometimes seen within the carpal tunnel, which leads to compression of the median nerve. Ultrasound not only uses in diagnosis, but also can be used in guiding the needle to the particular point. So this is the median nerve. So the important point is to get between the palmaris longus tendon and below it, below the median nerve, and not to touch the median nerve. It's very, very important, because if median nerve is pricked, that creates a huge pain to the patient, then you cannot even do the procedure immediately. So it is just putting the needle under the median nerve and injecting the steroids. So this is regarding MR. MR is very, ultrasound is very, very dynamic, and it can be done in a very, very comfortable way. We compare, there are 3 triads, 3 signs, and one is to compare the thickness of the nerve in the proximal and distal segment. Now, MR has a very, very good sensitivity. The problem between MR and ultrasound is they don't have the same cutoff values for the cross-sectional area of median nerve. This is because in ultrasound, generally we give a slight compression to the nerve. So that compression actually takes, that is plus approximately minus 5 millimeters square on ultrasound. But actually on MR, there is no compression on the median nerve. So generally, we take the cutoff of 15 millimeter square in MRI, which is normal. Whereas in ultrasound, we take the cutoff about 10 millimeter square. Again, MR is very, very specific in detecting mass lesions, especially rheumatoid arthritis changes and normal variants like bifid median nerve. As I told you, you can see here, 15 millimeter square is the cutoff criteria here. So in MR, you can see here, this is the unaffected hand, unaffected, again, affected hand. Here you could see that the median nerve is thick compared to the opposite side. You could see here the flexor retinaculum is definitely bowed. Flexor retinaculum is definitely bowed here, and that can lead to thickening of the flexor retinaculum at the level of hook. Now, this is a case where importantly we need to find where the palmar cutaneous branch is. So see, this is the palmar cutaneous branch, and we need to understand where the palmar cutaneous nerve branch looks like. This is a case of, again, a thickened median nerve, which is due to the tenosynovitis. You could see the fluid here and the thickening here, and you would always see the tenosynovitis, which causes thickening and compression of the top. You could see here, this is a stir image. This is called short tau inversion recovery sequence, where you suppress all the fat sequence, stir sequence it's called, and you could see definitely synovial thickening around the median nerve that is causing compression. And here the flexor retinaculum narrowing is not the pathology, but primarily the synovitis is the pathology. Now for this, MR becomes very, very, very useful. Again, this is how the cross-sectional area is measured, and this is how a thickened median nerve looks in MR. In case of rheumatoid arthritis, there is a lot of destruction around the distal carpal bones, especially the radiocarpal bones, as well as the first metacarpophalangeal joint. And there is multiple destruction and areas of synovial thickening. That can lead to synovial thickening within the carpal tunnel and cause compression on the median nerve also. So again, the findings are same, but if there is a cause, that needs to be addressed and diagnosed with. Again, this is a case of very rare case with a very old case of mine, and you could see that's the median nerve tumor that was sitting inside, and this was dissected and this was removed actually. This was operated elsewhere. So this was a tumor sitting in the median nerve. Post-operatively, also sometimes patient, after the release of the retinaculum, sometimes patient develop the pain. In those cases, if we image, there will be thickening of the flexor retinaculum again. This is due to postoperative fibrosis that can lead to recurrent carpal tunnel syndrome. So this is the median nerve. So because of the thickening, you could see obviously there is thickening of the flexor retinaculum there. There are a lot of mimics. I think this was beautifully covered by my previous speaker, Dr. Vijayan sir again. So the clinical history is absolutely important. Physical examination is absolutely important, where anterior recurrent anterior intraosseous nerve compression and the brachial plexus and the there's going to be radiculopathy due to any disc in the cervical spine has to be evaluated. This can be evaluated only by the clinical history and physical examination. So as radiologists, we generally do the investigation what the clinicians ask for. Sometimes if the clinician gives us the history and we are not able to pick up a proper diagnosis in the area of scan, generally we go up and screen the brachial plexus and the cervical spine. So this is in short regarding the basics of how we image the carpal tunnel syndrome. Thank you.
Thank you, Bavaharan sir.
Nice lecture, sir. Thank you. Power, sir. Thank you.
Now we will have the second question. Naveen. Which is the clinching point which distinguishes carpal tunnel syndrome from median nerve damage more proximally? This is from the anatomy question. You need to answer it. It's a bigger answer only. So Okay, now we will go for the next lecture by Dr. Thiruppathy sir, who was the main person, architect for this today's program. And Naveen. Dr. Thiruppathy sir is graduated from the Tanjore Medical College and MCH from Madurai Medical College, and microsurgical training from AIMS New Delhi, and fellowships in KIM Hospital Mumbai and Fujita Health University Japan. Postgraduate diploma in medical law and ethics, and various responsibilities. He is the active member in the office bearer in the Madurai Neurosurgical Academy and Indian Medical Association, and in the PPLS also he is one of the active district coordinators. Presently working as a senior consultant neurosurgeon at ABC Hospital and Apollo Speciality Hospital. He has publications and presentations in the various national and international levels. Dr. Thiruppathy sir, it's all yours.
Thank you. Screen is visible, sir. The screen is
we
visible.
can see.
Yes, sir.
Yes, we can see it, Dr.
So this is actually a team which we get into before going to the surgery. And actually, to be honest, I learned this technique from a plastic surgeon colleague, Umar Shankar. And so just I'm not going into these details now here. Okay, fine. Okay, fine. Let us get into. So, okay. So diagnosis, most often diagnosis comes from the combination of correlation. Rather than combinations, a correlation of history, clinical examination, and nerve conduction study, plus or minus imaging, as beautifully demonstrated by Bavaharan. So there's a correlation. So what are the surgical indications? And Dr. Vijayan told the patient will not be forgiving you for some mishappenings there. I would say that if you are getting into a correct correlation and picking up a correct surgical indication, patient will be more thankful to you. Two things are there. Most cases, since most cases are bilateral, you always, if he is thankful, he comes with another hand within next few weeks to you. So indication is you have to correlate history, clinical examination, nerve conduction study, plus or minus imaging, refractory to medical management, neurological impairment, sensory loss, atrophy or weakness. If bilateral, more severe site should be operated first. I usually prefer next site after 6 weeks, making the other hand more functionally or more easily convincible and acting. And one caution, most bilateral cases happens during pregnancy. And usually these symptoms of carpal tunnel syndrome subsides after pregnancy. So if a case of pregnancy, we can wait if patient is able to tolerate the symptoms without any neurological impairment. Otherwise, you can see after end of pregnancy, it resolves on its own. So let us not put the knife during pregnancy as far as possible. So as a surgical point of view, how we do it, these are the basic investigations we go for it, like grouping, typing, correlation profile, urea, sugar, creatinine, and ESR is very important. TSH, RA factor, and serology, ECG, X-ray, chest as warranted, and can be done under local anesthesia, but we prefer regional anesthesia with ultrasound guided regional anesthesia, and specific instruments, what to keep in the table for it. Microscope, loop may also be used, can be used, hand table, tourniquet. People, there are two schools of thought, tourniquet may be necessary or may not be necessary, but I prefer to have tourniquet in place marker, number 15 surgical blade, bipolar cautery, self-retaining retractors and Langenbach's retractors, our routine Hudson elevator, our dural and vascular scissors, nerve probes, and 40 epilon. These are the specific instruments and gadgets and consumables which we have to keep ready before going for a surgery. So operative steps, just one by one step I go, and finally we go to the video of this. So tourniquet is applied after hand elevation. That's very important. I usually keep around 220, and single dose of antibiotic is given just at the induction at the time of just before after tourniquet. And usually people in the tourniquet people will not apply after hand elevation. That causes a lot of problem. You should be very, very careful. The tourniquet should be applied after elevating the hand. And microscope is being used right from the skin incision. Right from the skin incision is being used. And there is a curvilinear incision is made just distal to the wrist, crease. And what I prefer is I never use cross this wrist crease. Because initial cases, to make the surgical easy, we were crossing the wrist crease. The problem is the patient had a severe pain, tenderness problems in this area. In this area and the wrist crease. Be sure, because we are using a microscope, we can take the advantage of the microscope. There's definitely a few millimeters just distal to the wrist crease is the starting point. To a point in the line with the distal border of the extended outstretched thumb. This is so just not this diagram. Just before the wrist crease up to the distal border of the outstretched thumb. This is the incision. And 2 to 3 millimeter just medial to the volar crease, not at the crease. You should not put the incision at the crease. That is very important. Very, very, very important, because that causes innumerable functional problems there. And in line with the long axis of the long axis of the ring finger, and the incision to be in the depth of the subcutaneous fat. So these are the very, very important steps we should go the surgery. And self-retaining retractors are placed, or plus or minus Langenbach retractor. Visualize Pharma aponeurosis incise in line with the skin incision. Graded retraction should be given in each step. The transverse ligament is exposed. Okay. So this is very important step I want to say here, because this is a fat globule pops up immediately at the distal end of the incision of the exposure. This is a relatively a constant landmark where you can start your dissection, cutting incision of the carpal, the transverse carpal ligament from here. This is I would say that almost 100% of the cases, this fat globule pop out. Okay.
Speaker sir, kindly unmute yourself, sir. Speaker sir, kindly unmute yourself, sir. Speaker sir, kindly unmute yourself and speak, sir.
Dr. Thiruppathy, unmute yourself, please.
I think I'll go back again.
Yeah, go back to the previous one.
Something back. Okay, this a description. Hello. This slide.
Yeah, this slide is okay. From the next slide we need.
Now the Hudson elevator is passed underneath the ligament from the distal end. The dissection and cutting should be from the distal to proximal. Ligament is, you keep the Hudson elevator as a protective mechanism between the nerve and the ligament. Ligament is sharply incised. You can incise with the 15 blade or cut with the scissors. And depending upon the pathology of the ligament, and slowly you advance with the Hudson elevator proximally. Next slide. So the sectioning is extended proximally until the deep fascia of the forearm is reached. And you can easily, since we are using a microscope or loop, you can elevate the hand and 30 to 60 degrees from the elbow, and microscope will be inclined to see through the to the gap in the forearm, and the median nerve is visualized and freed from any adhesions, and neurolysis is not required. So the freeness can be ensured by passing our usually nerve ball probe above the median nerve across the wrist to the distal forearm, and saline irrigation is given, thorough saline irrigation is given, and tourniquet is released. Significant bleeding points cauterized with bipolar coagulation. We prefer a single layer closure with force ethylene. Resplendent is applied over the dressing. And I come to just a minute. Screen sharing. So some other video screen share. Just on this. How to minimize this? Just a minute. Okay. Sir, I will stop share and come back to the video again, sir. Just a minute. Okay. Now I will share screen, desktop, share. Videos visually, sir?
It's too small, you have to enlarge it. Yeah, now it's good.
Okay, fine. Now it's okay?
Yes,
Now,
it's
let's see
Yes.
video of one of the cases. And now it is slowly, sharply incised. Hudson is, elevator is inserted. And it's cut with our dural scissors. Slowly advance proximally. Slowly advance proximally. And it is free from all adhesions. This is a median nerve. It's a microscopic view. And now you pass the Hudson, our nerve probe here, and you can insert way to the forearm and see the freeness has been ensured with this. And a single layer closure is being done. So thank you. And I'll come to the slide again. Please. Okay. Discharge after recovery of the anesthesia is a day care procedure, same day. The prescriptions, what we prescribe are paracetamol for 2 days, pregabalin, vitamin C, and neurotropic vitamins. The instructions is hand elevation, regular cleaning and dressing of the wounds. Routine hand movements can be done from the day one, active and passive, and suture removal after 2 weeks. And further reading is suggested from our Shetty Rangachari book, and there's a good article about in Fessler and Shager's Atlas of Neurosurgical Techniques, Spine and Peripheral Nerves. And what I would say is it's a very rewarding procedure if proper case is selected. And always you get a 2 mostly bilateral cases. You get two cases at a time. After 6 weeks, you can both hands can be done. Patient will be thankful. Yeah. And it's an outpatient procedure, essentially outpatient procedure. And another thing I want to say that actually sometimes the insurance companies are paying you more than a meningioma. Thank you. Thank you. Ajay sir.
Thank you, Thiruppathy sir. Now we will go for the third question. Third question. In carpal tunnel syndrome, the terminal phalanx of the thumb can be flexed with the normal power. How? In carpal tunnel syndrome, the terminal phalanx of the thumb can be flexed with the normal power. How? Okay, we can go for the discussions, and in between we will be asking other questions. Yes, sir. Yes, sir.
Good evening. I congratulate Thiruppathy and all the presenters for wonderful program. It's an excellent thing, and one of the common problems we encounter. And though it appears simple, but it is not so simple as it thought to be. And very informative from anatomy. Madam spoke extensively about these minute aspects of the anatomical structures, arrangement, and also the anatomical variations. It was a good knowledge sharing. Secondly, Dr. Vijayan spoke extremely very nicely about this clinical features and radiological. About the electrophysiological assessment and about the differential diagnosis of carpal tunnel, including the double crush, which has to be highlighted. And also the sonologist, radiologist spoke also very nice imaging pictures of MRI pictures of carpal tunnel and ultrasonogram pictures also have been shared nicely. And Thiruppathi's videos, very nice actually. He has shown a nice microsurgical incision about and release of the carpal tunnel. My one comment is, we use, you have used only the tourniquet with local anesthesia.
Regional anesthesia.
Actually, the block. You mean
Block.
okay. We use actually in Chettinad Hospital, we use the Bayer's block, the intravenous regional anesthesia, and it has given. We are very happy about it. We have done nearly 75 to 100 cases roughly with the intravenous regional anesthesia, and the recovery is almost immediately. Patients, anesthesia effect goes almost within a few minutes. So it's a very good procedure. Probably axillary block, maybe that may take some time to for the effect to wane off. So maybe this Bayer's block will be more useful in such cases for them to recover early. And another one I want to know, probably Thiruppathy could have highlighted on now people are using the endoscopic release. Probably I don't know anybody here is doing that, but it's also found to be useful.
But I don't have any experience. I don't have any experience in that.
Yeah, these are the 2 points I want to highlight. Thank you. Probably this was one of the largest attended. More than nearly 500 people attended this. Probably very popular. Rajesh Babu is very popular. Program has become very popular, and Rajesh Babu should be congratulated for that.
Can I proceed with some discussions?
Sir, now we will go for the fourth question, sir. And then discussion. Fourth question, Naveen. The most often working correlation for surgical indication. A, symptoms and signs. B, nerve conduction study. C, symptoms and signs and nerve conduction study. D, symptoms and signs and imaging. E, symptoms and signs and nerve conduction study imaging. Okay, we will carry on with the discussion. And then after some time, we will go for fifth question.
Okay. Now I want to have a discussion with Dr. Vijayan. Vijayan, sir.
Sir, yes, sir.
Another important difference when it comes to diabetes, because most patients are diabetic patients. So it's a peripheral neuropathy is important consideration is there. So what will you clinch here with both electrophysiological and clinically on this side?
Carpal tunnel syndrome itself is a manifestation, one of the manifestations of diabetic peripheral neuropathy. One of the compression neuropathies of diabetes is carpal tunnel syndrome itself. Electrophysiologically, it can be easily distinguished just by comparing the other nerves. It can be very easily differentiated from. We can have carpal tunnel syndrome alone in diabetes. We can also have carpal tunnel syndrome superimposed on diabetic peripheral. Both very easily can be distinguished by nerve conduction study, even by clinical examinations. Routine clinical examinations.
Okay, fine. If another question is the double crush syndrome is there, double crush. What do you suggest to deal which one first? Whether carpal tunnel or the cervical, which you prefer? We can or both at the same time.
Definitely not both at the same time. Depending upon the symptoms, again by history, clinical examination, we will know which is more severe, sir. The nerve conduction. So based on these findings, only we will have to know.
Okay.
Whichever is more severe.
More severe. But if it becomes a difficult job, you have to deal one with the time. Which is for, you have to deal both. Okay. Which you prefer to deal first? Then see, evaluate, then go for again.
Obviously, the carpal tunnel first, and then go.
Okay, fine.
My thing will be whatever the proximal lesion has to be dealt with first. Probably the disc lesion has to be tackled first, then the carpal tunnel. If both are there.
Fine, sir. Is there the recurrence rate after steroid injections? Steroid injections we are discussing, Bavaharan and Vijayan. What is the recurrence rate after steroid injections?
Very clear, sir. Steroid only for mild and early cases of carpal tunnel. Even for moderate and cases, steroid injections will not work. Steroid injections may help to buy time before surgery too. The recurrence rate is very high. You have to sometimes keep on injecting steroids. Maybe once in 6 months, once in a year. It depends again upon the patient. So recurrence rate is very high. It is not a cure for carpal tunnel syndrome. Always microsurgical release. It works well in mild and early cases.
And now I want to have a discussion with Dr. Bavaharan. Bavaharan, are you there?
Yes, sir.
Okay. We have a very good and reasonable clinical diagnosis, and electrophysiological correlation is there. Mostly idiopathic or maybe diabetic or hypothyroid correction is there. How dare you pitch imaging as a mandatory or not?
Imaging generally is done not only to actually diagnose the median nerve compressions, it's also to rule out the other causes. Suppose if directly a diabetes, pregnancy, everything is there, but to rule out if there is any tenosynovitis, and sometimes, the flexor tendon may have a lot of fluid around it. That can actually get into the carpal tunnel, and there can be synovial thickening in the carpal tunnel, which has to be evaluated. Sometimes associated rheumatoid arthritis. Only in those conditions actually clinical. See, many of the studies are very clear, where if the nerve conduction studies are very clear about carpal tunnel syndrome, a direct microsurgical release is being done without any imaging is actually done. So that's a very clear mandate on that.
Okay. What I want to emphasize is rheumatoid arthritis, yes, but when you get the fluid contents on there, no. Whenever I find few cases when you release it out, the fluid also comes out. When you open it up, that also get released automatically. Some synovial fluids we have seen. We have taken some synovial fluids coming out, and some ganglions was also present sometimes. That also opened up, and even the more thickening we deal with. After we are going to release it there.
Yes, sir.
So, so what do you do is, okay, if we have not much correlation between clinical and electrophysiological, we can take alone imaging and go for it.
See, imaging will definitely give you, whether it is cervical spine MR or you're going to do any nerve pathology, MR gives you where the lesion is. Surgical or medical management depends purely not on imaging modality. It depends upon the clinical evaluation. We have to be very, very clear. See, if MR gives C4, C5, we would have seen larger disc at C4, C5, which the patient will not have any symptom at all, where there will be a smaller disc, much smaller disc compared to which will have symptoms. So MR gives you the level where the problem is. But whether to go for a surgical management or to do, in this case of radiculopathy or carpal, depends purely on the clinical evaluation and the symptoms of the patient and the neurophysiological tests.
This discussion was actually to have a clear-cut answer on these lines. That's why. And any other questions, please? And I want to ask another thing, Bavaharan. That's a of congenitally small canal is there. Congenital small canal, which gets aggravated in the age course as ages advances. Is there?
Yeah. See, you meant to say about skeletal dysplasia conditions.
Congenitally small narrow canal is entity is being proclaimed also. It's there.
See, there is no exact surgical, size criteria for imaging is concerned, sir. We again have to go on the median nerve compression and the dilatation at the level of compression and the cross-sectional area. Because see, on ultrasound, it's very difficult to evaluate the entire area. What is the exact area of the cross-section? We are actually taking a point where we take the cross-section area. We are very precise about it. So in those conditions also, the findings almost are the same, where ultrasound and MR, the findings are almost the same. So there is no different or a specific criteria for a smaller carpal tunnel in case of skeletal dysplasias or smaller congenitally smaller tunnels. We have to find out the costs. So sometimes, as we all said, the median artery, or it could be a bifid median nerve, or sometimes there may be a extra, is there any other extra muscles or extra thing which is causing compression on the median nerve? So that has to be addressed, sir.
Now we will go for the fifth question, sir. If competent, which specialist surgeon can perform CTS surgery? Plastic surgeon, orthopedic surgeon, neurosurgeon, all of the above.
This is a political question.
Now we will continue the discussion. There was one question in the chat box, I think.
Let me see.
Yeah, Nishant wanted to ask that question. Nishant,
Latencies are a function of distance, right?
Yes, sir.
What is the distal distance for which 4 millisecond AMS is the cutoff?
Vijayan?
Vijayan, sir?
Vijayan is there? Who was there?
Vijayan, sir?
Nishant, can we hear from you?
Yeah, sir. So the point of asking this question is that the testing, there are a lot of nuances. So whenever I see reports or whenever we talk about cutoffs, it's very important to also mention the distance. So where to put the active electrode, where to put the recording electrode, and distance measurements have to be extremely precise. And these cutoffs, 4 millisecond, 4.4 millisecond, whatever you use depends on the testing methodology that you are using. So that's the point I wanted to ask, highlight for electrophysiology. And there is another index, a specific index called combined sensory index. So it consists of 3 tests, and it basically compares median and ulnar differences in sensory latencies, median and radial, and there is something called mixed nerve conduction study. We know we usually talk about motor conduction study. We talk about sensory conduction study. There is something called mixed conduction study where we, pick up action potentials from the entire nerve. So the sum of these differences, if it is above 1 millisecond, it clinches the diagnosis. And there is also a grading system based on these parameters. So that's why, I thought of asking this particular question. And this question, how to distinguish carpal tunnel syndrome in a patient with pre-existing distal symmetric polyneuropathy, common form of diabetic neuropathy, that also Thiruppathy sir highlighted. And many times, clinicians ask about inching study. So, I just wanted to know from Vijayan sir, how often we have to do, or is it like mandatory to do in all patients, or when does he practice?
I think Vijayan is not here. Vijayan just is gone, I think. He got disconnected, I think so.
So how I do is that whenever the difference in latencies is not obvious, we add it as a test. Whenever it's not obvious with routine studies, we can go for inching study. And even the differentiating diabetic neuropathy with carpal tunnel syndrome, inching study can help in clinching. So both will have prolonged latencies. But if you can prove selective prolongation across the carpal tunnel, then it points in favor of carpal tunnel syndrome rather than distal symmetric polyneuropathy.
Dr. Nishant, should we do EMG also in these cases?
No, sir, not usually done. In private practice, especially, it adds on to the cost. So you should. So mostly with motor and sensory conduction studies itself, we can reliably. So if you look at electrophysiology texts, in order to distinguish radiculopathy from carpal tunnel syndrome, you have to do EMG of the paraspinal muscles and all. So it's only described theoretically, but hardly it's being practiced.
We will go for the next question,
Yes.
Sixth question. What is this study called? What is this study called? Sir was mentioning about this in detail. Bavaharan sir. Okay, we can carry on with the next question, next discussion.
Vijayan வந்தாதான் டிஸ்கஷன் அதுல வேற ஏதாவது
ஆக்சுவலா விஜயன் சார் ஏதோ எமர்ஜென்சி ஒரு பேஷண்ட் ஏதோ அரெஸ்ட் போயிடுச்சாமா
நோ ப்ராப்ளம்
வந்து வர முடியலன்னு சொல்லி சொன்னாரு.
Carpal syndrome is never an emergency.
Now we welcome our Dr. Suresh Jayapalan sir, who is now in UK. I welcome you, sir. Any comments about the carpal tunnel syndrome? Your experience, you can talk.
Sir, unmute பண்ணுங்க sir. Unmute.
Sir, I just joined. I'm very happy. Almost 500 participants. I just saw 499. That's why I joined to make it 500. Sir, Murugan sir.
Yeah, all good.
Yeah.
Nice of you to join.
Good. Thank you, sir.
You're in a different time zone, so nice of you to join.
I don't know. Please continue.
I think.
Sir, one question to Thiruppathy sir. Sir, do you use nerve conduction studies? So I'm an electrophysiologist, so my questions will be related to that. So do you use studies to assess the success of the surgery, or if there is any recurrence? Do you use it? I mean, practically.
Touch wood, since the indications were very correlated and taken back, the patient has clinical improvement, symptomatic improvement is a yardstick. That's all. Never I have done no study or post-operative, definitely. Because if there is symptomatic relief, what is a big deal about that? But yes, as I said,
only in patients with recurrence or patients who don't, or there is,
touch wood I have not got.
Just a question. I just wanted to know how many patients in anybody's experience has improved even without a surgery, just with the conservative treatment. After confirming that it's a CTS, patient comes with clinical symptoms. We did a electrophysiology, proven CTS, but after that improved.
Yes, exactly. Two things I want to answer. One is, if the patient comes with the symptoms alone, we always prescribe a medical management, first line of treatment. Definitely more patients who are really suffering will ask for surgery. They will ask for surgery. It is not, sir, for them it's very painful. They will ask for surgery. If the patient is asking for surgery, that is a clear indication for it. And we recommend surgery the first shot where there's a motor weakness has started. Motor weakness has started. It's a late phenomena and severe CTS in the electrophysiology. And what we tell them is, this motor weakness is not going to come back immediately, mostly. This is to prevent further motor weakness or wasting. The indication is of surgery is here only to prevent further deterioration in some problems, not that. So, some significant patients do well with some activities, with the lifestyle modifications, or with good, better diabetic control. Sometimes more, or even so rheumatoid arthritis, they go for treatment, they get symptomatic relief later date, which we cannot guess. But surgical indications, after giving a fair trial of conservative management, along with treatment of the causative factors also, patient definitely, if he needs surgery, he will come back to you. That's my point here.
Now we will go over the 7th question, sir. What is the name of the structure that is marked in yellow? Okay, we will continue.
Yeah, that's great. Most of the time, patients will improve even without a surgery. And I think most of surgeons are obedient CTS patients only. Myself had a CTS maybe 20 years back doing MCH neurosurgery itself. Diagnosed as CTS, but continue to do the job and operate. That's why I just wanted to know from.
Never as a first shot we are offered surgery. Never on a single occasion. Unless I say the motor weakness is there. Objective weakness.
Thank you.
Future, hope future, you don't ask for it. Okay. Rajesh Babu sir.
Now it is the time for last question. 8th question.
Correct.
In MRI, an increase in the cross-section area of millimeter square between the medial or proximal third probable quadratus level and in the carpal tunnel is very specific.
அது சும்மா விளையாட்டு சொன்னாலும் நம்ம தெரியலையே. போன் எடுத்துட்டு வந்தா அது
Doctor, I muted all. Kindly unmute yourself, doctor, to speak.
Okay. Okay, we can carry on the discussion. Ms. Kodiswaran sir, any comments?
Sir, truly speaking, I am
Sir.
also a patient of carpal tunnel syndrome for more than 20 years. Because I
You are
got this
treating
problem in,
conservatively or undergone surgery?
the only secret for me is only conservative management. So whenever I get a patient with carpal tunnel syndrome, I strictly advise them medications with rest, with wrist splint. Most of them is settled down. So I have operated almost only 2 patients, as Dr. Thiruppathy said, with motor deficits in the past 15 years.
So Suresh and Kodi, were you diagnosed only clinically, or did you have neurophysiological study or MRI also or ultrasound also?
Clinical diagnosis, sir.
What about you, Suresh?
For me, clinical and neurophysiological, not MRI. That time, I don't think we do MRI.
In 2004, when I was a PG, I started developing these symptoms. And I almost prepared to get operated in 2004 itself. After that, I started using that wrist splint. Then the pain was reduced. So whenever I get a pain, so I used to apply this wrist splint for a few days. Most of the time, the pain will go off.
Okay. Yeah, for me, I was actually patient in examination also. First is examination also. But I think somehow it's became all right with the medication. But it's not that we need to see the what is the reason for the CTS. Most of our patients comes with hypothyroid or other which they don't control.
In hypothyroid patients, if you correct thyroid issue, they will become normal, sir, most of the time.
Yeah. Some patient where we cannot correct, we don't know the reason, then obviously the surgery only will help.
Yes.
But since we know the reason, we know the physiology, we just got it. But most of the time when we do surgery, patients get enormous relief. We have done for a surgery for many patients. So they have enormous relief, and plastic surgeons and orthopedic surgeons, they do left and right. Every day they do 2 or 3 cases, and obviously patient asks for it. It's not that they just do.
No, the problem is we cannot sleep in the night, sir.
Yeah.
Because the comfortable position of the hand itself will take few hours when you get the pain. Actually, it's a very horrible symptom.
That's right.
As Thiruppathy said, the indication should be patient should ask for surgery. Like in those days, we used to say for peptic ulcer, patient should demand surgery. That is the only indication. Otherwise, I agree with Suresh and Kodiswaran. Majority of the patients can be treated conservatively, but still there is a good number of patients who need surgery, who ask for surgery because of the severe symptoms. It's not that rare, to do a surgery.
Especially what I feel is, other than office works, other things need to manage. The patients who are, especially female patients, who are not, they say that for disturbing for the household activities, because they have to continue that. That becomes for them a horrible affair. So the family also pushes because she cannot do her household activities. That is one problem which we encounter. Patient comes for surgery. Second thing, the patients who wear saris, they fold it, the saris, and they cannot do that. They feel very devastating on that. So the social angle, these 2 patients come forward to surgery earlier because the household activities, and patients who used to wear saris, they say that that is disabling. So these 2, which I came across in the practice, the female patient, they are happy about that, to coming and getting back to work normal. Other office works, they manage. But these two are very important areas. And these are the people who are always at more of the hypothyroid also they have. Thyroid problems also there in these, more of the female patients. Which is add to discussion. It's because of the functional incapacity to their tailored activities of daily living.
Can we have the answers now?
Hello?
Dr. Rajesh Babu, can we have the answers? Dr. Rajesh, you need to unmute.
He slept,
Sir,
I
we
think.
will now give the answers, sir. So the first question is commonest carpal bone which get dislocated. The answer is lunate bone, and the winner is Trinath. Trinath is the winner. Trinath is available there.
Yes, sir. Yes, sir.
You are from which college?
Chettinad Medical College, sir.
Huh?
Chettinad Medical College, sir.
Okay. Congratulations. The second question is, which is the clinching point which distinguishes carpal tunnel syndrome from median nerve damage more proximally? The answer is sensory loss over the thenar eminence will not be there in carpal tunnel syndrome because palm or branch of median nerve enters the palm superficial to the retinaculum. That is the answer. And the winner is Sivasubramanian. Sivasubramanian is there. Sivasubramanian is not there. Now the third question is, in carpal tunnel syndrome, the proximal phalanx of the thumb can be flexed with normal power. How? The answer is flexor pollicis longus, not paralyzed in CTS. There was no correct answers and no winners. And now the fourth question is, the most often working correlation for surgical indication is symptoms and signs and nerve conduction study. C. And the winner is Dr. Balamurugan. Balamurugan is there? It's not there. Now, fifth question. Fifth question is, if competent with specialist surgeon can perform CTS surgery, answer is all of the above. And the first response is from Trinath. Once again, Trinath is there?
Yes, sir. Yes, sir. Thank you, sir.
Congratulations, Trinath. Now the sixth question is, what is the study called? The study is called as dynamic ultrasound. And the winner is once again Trinath. And the seventh question is, what is the name of the structure which is marked in yellow? The response is median nerve is the answer, and the first responder was Pranshu Mehta. Pranshu Mehta is available?
Yes, sir. From Meenakshi Mission Hospital, sir. Meenakshi Mission Hospital, Madurai, sir.
Congratulations.
Thank you, sir.
Congratulations. Now the eighth question is, in MRI, an increase in the cross-sectional area of 4 millimeter square between the median nerve at proximal third probable quadratus level and in the carpal tunnel is very specific. The winner is Jaya. Jaya is available there?
Yes, sir.
You are from?
Tirunelveli Medical College.
Huh?
Tirunelveli Medical College, sir. Final year DM Neurology.
Huh?
Tirunelveli, sir. Tirunelveli Medical College.
DM Neurology.
Yes, sir.
Congratulations, madam.
Thank you, sir.
So congratulations to all the winners, and the prizes will be given to you at your place. Any other things? Any other people want to talk anything about it?
Thank you very much, sir. It was an interesting program throughout. I watched. Thank you for once again for giving me the opportunity. With your permission, I am ready. Thank you.
Sir. Yes, Babu, sir.
Dr. Kodi, time for vote of thanks.
Actually, first time TANS involved other specialists for this CME. So it's a good innovative idea by Dr. Rajesh Babu sir and Thiruppathy sir. It was a wonderful knowledge sharing session. Another record, this time the 7th CME hit 500 participants. This is the first time we are crossing this landmark. So one of the good milestone for TANS CMEs. So I would like to congratulate our TANS team for this. And I would like to thank everyone for joining this CME. Good night, and we'll see you with a good topic next time. Thank you.
Thank you all. Thank you.